Genc. I'm from. Okay, wonderful. Okay, my name is Mehmet Genc. I'm a faculty at the University of Florida Department of OBGYN, Maternal Fetal Medicine. First of all, I would like to thank you for everyone who's participating and taking time off from their family time and from their dinner. I welcome you to the first pregnancy and liver disease presented by the American Liver Foundation. I will co-chair this series along with Dr. Ali Zarimpar, who's also a faculty at our institution, and we are excited to have you here today. The mission of the American Liver Association is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. You can find more about their professional programming, such as upcoming programs, update on liver transplantation and health disparities in liver disease, a focus on women's health on their website at www.liverfoundation.org. Request for credits will be available next Friday, June 25th, and you have received an email on the steps to requesting credit. Before we get started, I would like to introduce Ms. Ivory Allison, the National Manager, Outreach and Education for the American Liver Foundation, to review some of the housekeeping rules. Ms. Allison.
Thank you so much, Dr. Genc. We have on our screen our Zoom webinar details, and we want everyone to know that this program will be recorded and will be available for on-demand viewing. Attendees will receive a link via email. If you have any questions, please type them in the Q&A feature or the chat. We will be monitoring them throughout. We have a disclaimer to let everyone know, again, that this is being recorded, and we will upload it to our YouTube channel and send an email out to everyone. I will now turn it back over to Dr. Genc to start the program.
Thank you, Ms. Allison. So let me share my screen and hold on 1 second. Do you see my screen?
Yes.
Okay, wonderful. So we have three topics, and I would like to have a discussion session at the end of each topic. The first topic, the liver disease is specific to pregnancy. And the first presentation is mine, and then my presentation will be followed by Dr. Wen's presentation. So so I'm the first presenter, and I would like to talk about intrahepatic cholestasis of pregnancy, which is uniquely a pregnancy-related situation. I have no financial relationships to disclose in relation to this content of this presentation. Our learning objectives are to assess a pregnant woman with pruritus but no rash, determine the risks for maternal and perinatal adverse outcomes following the diagnosis of intercholestasis of pregnancy or ICP, and plan the management of prenatal care for a women with ICP. So the definition of, I think we have some echoing, so if you can mute your microphones, thank you. So ICP is the pruritus with the outrash, but with abnormal liver functions. And it's, as I said, it's exclusively unique to pregnancy. It usually presents itself in the second and the third trimester. There are very few case reports presenting in the first trimester, and you can rarely have ICP while you're on birth control pills or some other hormone replacement. It's first described in 1887 but it took 8 years for us to realize that it's also associated with.
Dr. Genc, I apologize. They can't see your slide.
Oh, they cannot?
No.
Please. Okay. Hold on 1 second. I'm sharing my screen again. How about now?
Yes. And if everyone can go on mute, that'd be great.
Okay, I guess I'm going to take from the slide number 3. Again, can we please mute? Thank you. So I'm going to take
Ivory, I think it's
again from
it's your phone.
pardon me. Okay, I'm going to take from slide number 3. So as I said, ICP is a pregnancy-related condition. It usually presents in the 2nd and the 3rd trimester, very rarely in the 1st trimester. There has been reports that it's associated with hormonal replacement, particularly with oral contraceptives. It was first described in 1887, but it took 80 years to realize that it's also associated with adverse pregnancy outcomes. Again, I say without rash, but it may be difficult to differentiate the rash, because these patients, they would often present you with scratch marks which may resemble the rash. The pathophysiology is poorly understood. It's obviously the stagnation of the bile flow. There are genetic, environmental factors, as I said, hormonal factors, and it's usually associated with pre-existing liver disease that is not diagnosed. The prevalence shows significant variation, probably attributable to the genetic variation in the population. It's particularly prevalent in South America, in Bolivia, where the prevalence can be as high as 14%. In Chile, where the prevalence can be as high as 28% in certain populations. In Europe, the prevalence is much lower, and Scandinavia is an area where the prevalence is the highest, approximately 1 to 1.5. In the United States, the prevalence is approximately 0.3%, but it's much higher among the Latina population, around 5.6%. So the laboratory diagnosis is established with elevated total bile acids with or without transaminitis. And in pregnancy, typically, desoxycholic acid, a fraction of the bile acids, is elevated, but in this disease, cholic acid is elevated, is the predominantly elevated bile acid. Fasting increases, following feeding is associated with a greater bile acids, and therefore fasting is recommended to increase specificity, but it's kind of difficult to achieve in our population. So random blood tests are acceptable, and total bile acid levels greater than 10 micromole per liter in the presence of pruritus is considered diagnostic. There are a number of conditions that we need to differentiate because a number of other conditions can present with elevated bile acids. As I said, fat state is one of them. Pregnancy is another state where bile acids are elevated, and you can find pregnant women with elevated bile acids greater than 10 micromole per liter without any symptoms. Liver disease, infections, malignancies, certain drugs are all associated with elevated bile acids. There are conditions that are associated with pruritus without rash. Again, liver diseases, renal diseases, thyroid conditions, infections, and malignant conditions, and certain drugs and certain psychiatric situations. But you know, probably the most common condition in a pregnant woman who is known to be healthy and who presents with pruritus and elevated bile acids is the ICP. But I'm just pointing this out so that you keep that in the back of your mind. So what happens if you have a patient that is itching but with normal bile acids? As I showed you in my previous slide, first of all, you have to rule out other causes. The second explanation could be a delay in the rise of bile acids, and this can be as long as 4 weeks. For that reason, you may want to repeat the laboratory tests. And some people would choose to start empiric treatment, but obviously that may mask the elevation in bile acids, and you can never make a definitive diagnosis. So, as I said,
I'm sorry, you sound slide 4.
I'm still at slide 4?
Yes.
Jeez.
Can you put it in slide view?
Is that
Yep.
any better? I'm trying to put it on a slide view, but I guess I have 2 screens, so it's showing up on a different.
Oh, I see.
And for that reason, I'm not capturing that screen. I guess that's my problem. So I will, if the slides are not changing, just let me know.
Okay.
So why do we care about ICP, apart from the discomfort it gives to the patient, the pruritus? Because it's also associated with adverse maternal and perinatal outcomes. Adverse maternal outcomes include gestational diabetes, preeclampsia, postpartum hemorrhage, and future presentation of liver disease. And that's probably because of undiagnosed underlying liver disease. But the real concern is really the perinatal adverse outcomes, which include stillbirth, respiratory distress syndrome, asphyxia, meconium-stained amniotic fluid, and meconium aspiration, both spontaneous and iatrogenic preterm birth, and NICU admissions. So our understanding about of the pathogenesis for stillbirth attributable to ICP is poor. It is thought that the bile acids can induce fetal arrhythmia and cause vasospasm on the placental chorionic surface vessels. The risk in the United States, in the US, attributable to ICP for stillbirth is 12, whereas the risk of intrauterine fetal demise in the general population is 1 to 3 per 1,000. And 90% of the stillbirths occur after 37 weeks. The bile acid levels correlate with adverse outcomes in singletons significantly. The stillbirth rate is approximately 3.4% when the bile acid levels are greater than 100 micromole per liter, whereas below that, it's similar to the general population. So the stillbirth rate really increases when the bile acid levels are beyond 100. There's also an association between the spontaneous preterm birth rate and bile acids, and the bile acid and the risk increases by approximately 2.7 folds when the bile acid levels, total bile acid levels, are greater than 100 micromole per liter. So, what is the treatment? We have several treatment options. The one that has been most well studied is the ursodesoxycholic acid, given 10 to 15 milligrams per kilogram, divided in 2 to 3 daily doses. Other options include cholestyramine, adenosyl methionine, rifampin in combination with ursodesoxycholic in resistant cases, antihistamines, and topical diuretics. Only ursodesoxycholic acid has been studied in randomized placebo-controlled trials. This is a Cochrane review from 2020, and basically what this meta-analysis showed us is that the treatment with ursodesoxycholic acid has a minimal impact on the decrease of pruritus. Out of a scale of 100, it decreases by 7.6 points on average. And unfortunately, this meta-analysis showed no significant effect on fetal distress or stillbirth, although the number of patients included in this meta-analysis for these adverse outcomes are very low, so the data is somewhat unreliable. Here's another meta-analysis that was published in Lancet 2021, and this meta-analysis used individual participant data. And again, it confirmed the previous meta-analysis that there's no significant effect on the rate of stillbirth among those who receive ursodesoxycholic acid. However, spontaneous preterm birth, meconium-stained amniotic fluid, and neonatal ICU admissions, and this is probably a reflection of the decreased preterm birth, is decreased among those who were treated with ursodesoxycholic acid. So I would like to end my talk with the 2021 recommendations from the ACOG and Society for Maternal Fetal Medicine. Measure serum bile acids and liver transaminase levels in patients suspected of ICP. In other words, in those cases with pruritus but no rash. Ursodesoxycholic acid should be used as the first-line agent for treatment of maternal symptoms. We don't have concrete evidence that this would alleviate any of the risks associated with adverse prenatal outcomes. Antenatal surveillance is recommended, although this is a grade 2 evidence because unfortunately in most of these cases oligohydramnios, growth restriction, or even abnormal fetal heart tracing does not precede the intrauterine fetal demise. Offer delivery at 36 weeks for those patients where the bile acids are greater than 100 micromole per liter because of the increased risk for stillbirth. Those patients with a bile acid level less than 100 micromole, they can be delivered somewhere between 36 to 39 weeks. Probably if their bile acid levels are less than 40, then they can be delivered closer to 39 weeks. All patients who are expected to deliver before 37 weeks should receive antenatal corticosteroids and avoid delivery less than 37 weeks without the laboratory confirmation of elevated total bile acids in patients with pruritus but no rash. So I'm going to end my presentation, and I do apologize for this hiccup because I'm using two screens and I don't know how to solve, or I didn't know how to solve this problem. But our next speaker will be Dr. Patrick Duff, who is also a faculty at the University of Florida, and he's a national and international expert on infectious diseases and pregnancy. And his topic is hepatitis in pregnancy. Dr. Duff, I hope you have a better luck than I am in navigating the Zoom.
Well, I'm going to pray for assistance from Ivory and make sure that I'm doing this right. So I'm unmuted, and let's see. Now I can share my screen, I think.
Correct.
And let's see. I want to do this. Okay. And Ivory, is it looking promising there?
Not yet. Try it again.
Are you able to? Now, I see my slides. Do you see them?
No. Try to hit the share button again.
Okay, because all okay.
It's a share screen button at the bottom.
So let me end the show.
Right next to chat. It should be share screen.
Okay, so I'm clicking on share screen.
Yes.
And I want to share. And then click on my slide presentation.
Yes.
Is it there now?
No. Let's see. I will. When you hit your slide presentation, it comes up, and then you can hit the blue share button when that comes up.
Okay, I'm sorry if I'm doing something wrong. So
No, it's so much.
So I'm playing from the start, but see, like when I do that, it's just the whole screen has the slides and it doesn't have, let me end it again. Okay, so we're back here and I'm clicking on share screen. But I think, and there's a blue button.
Yes, a
Blue
blue share.
says share, but
Because
when
once you click on your slide and you hit that blue share button.
But like, all right, let's try that. Now?
It's okay. I'm going to pull up your slides and share myself, and you just let me know when to go to each page, if that's okay.
Okay, so I should get out of here. Okay, all right.
Can you see my screen?
I sure do.
All right.
Okay. But now I can't advance this, only you can, right?
Yeah, so you just let me know.
Okay. Well, sorry for the false start there. I'm very appreciative that Dr. Genc asked me to participate in this symposium. He asked me to specifically cover the issue of hepatitis B and C And I'm going to just broaden the talk very slightly to take in hepatitis A and D because they share some of the epidemiologic features of the other two forms of hepatitis. So next slide, please. What I'd like to do is go over the obstetric and the neonatal complications associated with hepatitis A, B, C, and D. I want to focus particularly on the best diagnostic tests for each form of hepatitis, and then talk about the preventive and the treatment measures for hepatitis in pregnancy. Next slide, please. So again, the primary focus will be on hepatitis C and B, but we want to touch just briefly on hepatitis A and D. Next, please. So hepatitis A, I used the little cartoon character there from Peanuts. That's Pigpen, and he's meant to sort of represent the epidemiology of hepatitis A, because we think of that as being an infection that's spread by fecal oral contamination. So the concept there, a little bit unsettling, is that we, in certain instances, are enveloped in a cloud of fecal material that puts us at risk for transmitting and or acquiring hepatitis A. Next slide. This is an RNA virus. It has an incubation period of about 15 to 50 days. Now, interestingly, in children, when they acquire hepatitis A, they're usually asymptomatic. But most infections with hepatitis A in adults are symptomatic infections. Next slide, please. And the key to the diagnosis of hepatitis A is physical examination, with the most notable physical finding being jaundice and scleral icterus, as illustrated in the photograph. And the key diagnostic test that you want to remember is detecting IgM-specific antibody in the serum. Next, please. With respect to obstetric issues, there is not a chronic carrier state for hepatitis A, and with very rare exceptions, perinatal transmission doesn't occur. Next, please. The key steps to prevent hepatitis A are really taking advantage of the hepatitis A vaccine. There are two forms of the inactivated vaccine readily available commercially, Havrix and Vacta. These can be also, there is also a combined inactivated vaccine that includes the hepatitis B vaccine. Level 1 evidence shows that this vaccine is highly effective. The cost of each vaccination is fairly minimal. It's about $66 to $120, depending upon whether you're using a single dose vial or a multi-dose vial. There are very few contraindications to hepatitis A vaccine other than an allergy to any of its components. Next, please. Now, who in our obstetric practice should receive the hepatitis A vaccine? Certainly patients that are international travelers, children who live in endemic areas. Interestingly, I think the groundbreaking study of the hepatitis A vaccine was actually based upon a study of a group of individuals in New York State where hepatitis A was really quite rampant. IV drug users are good candidates for this vaccine. And then people who have occupational exposures, for example, veterinarians or people that work in primate research laboratories, are at risk. Next, please. Other vaccine candidates would be individuals who live in or work in chronic care facilities, anyone who has chronic liver disease, homosexual men, and people who receive frequent clotting factor infusions because of clotting factor disorders are also candidates. Next, please. For post-exposure prophylaxis for hepatitis A, many of us learned about using immune globulin or gamma globulin in that setting. but really the preferred agent, both for pre-exposure prophylaxis and post-exposure prophylaxis, is the hepatitis A vaccine, because it, unlike gamma globulin, provides durable long-term immunity. Next slide, please. The other advantages of the hepatitis A vaccine for post-exposure prophylaxis are that it's really an abundant supply. It's less painful to administer than is the gamma globulin. It doesn't interfere with other immunization schedules, for example, administration of Rh immune globulin, and it's relatively comparable in cost to gamma globulin. Next slide. Hepatitis B is a DNA virus. Worldwide, we estimate that there are almost 400 million persons who are hepatitis B virus carriers. In the United States, a little more than 1 million individuals are infected, and this is one of the most highly contagious of all the viral infections. Next slide, please. Hepatitis B is transmitted parenterally by sharing contaminated drug injecting paraphernalia. It can be spread by sexual contact. And of course, as obstetricians, we're concerned because this can be transmitted perinatally from mother to baby. Next, please. There are certain individuals in our obstetric practice who seem to be at increased risk for harboring hepatitis B chronic infection. Individuals of Asian ethnicity, Eskimos, individuals from the sub-Saharan region of Africa, women who are sex workers, and then homosexual men are at increased risk. Next, please. Other persons at increased risk are IV drug abusers, hemophiliacs, individuals who require multiple transfusions, as with hepatitis A, the international travelers, individuals who work in or reside in chronic care facilities, individuals with tattoos, particularly multiple tattoos and body piercings, are probably at increased risk. And we, as healthcare workers, are at increased risk. Next, please. This slide is very important. It shows the natural history of hepatitis B. And as you can see there, most patients outlined in the green portion of the pie chart develop an acute infection, mount an effective antibody response, clear the antigen from their circulation, and forever after are immune. There are about 10% of individuals who become chronic carriers, and they're the ones that pose a risk to their developing fetus and to their sexual partners. And sadly, there are a tiny percentage of individuals who develop not only acute hepatitis B, but fulminant hepatitis B, and go on to develop hepatic encephalopathy and succumb to their illness. Next slide, please. Couple of simple tabular summaries here. Hepatitis B has 3 key antigens. The surface antigen, which is the major indicator of both acute and chronic infection. The core antigen, and the reason that's important is because IgM antibody to that core antigen is the first to form and is the key diagnostic test for acute hepatitis B. And important to remember that antibody to the core antigen is not protective against chronic infection. To be protected, you have to develop antibody to the surface antigen. Now, another important antigen is the so-called little e antigen. Not every patient who is infected has that antigen, but when they do, that is the key indicator of high infectivity, high level of viral replication. And women who have both the surface antigen and the e antigen are at significantly higher risk of transmitting infection to their baby. Next slide, please. The key antibodies then are those that form in response to these antigens. If you're fortunate enough to develop antibody, IgG antibody to the surface antigen, that basically will confer lifelong immunity. The importance again of IgM antibody directed to the core antigen is that that's the best diagnostic test for acute infection. And the presence of anti-E antibody is very important in reducing infectivity, even though the surface antigenemia may persist. Next slide, please. This is a tabular summary that shows the serologic profiles in 4 different settings: immunity as a result of natural infection, immunity as a result of vaccination, acute infection, and then chronic infection. Next, please. I think that patients who have hepatitis B, pregnant patients with hepatitis B, should routinely be tested for hepatitis C if you're not routinely doing that anyway. As we'll see in a few moments, you also need to test these folks for hepatitis D, because the presence of both hepatitis B and D infection is a very important negative prognostic factor for developing chronic liver disease. If you have hepatitis B, you certainly need to be tested for HIV. Liver function tests should be done to evaluate for chronic hepatitis. I think if the liver function tests are altered, a coagulation profile would also be indicated to see if the patient's at increased risk for bleeding. And PCR is very important in evaluating these patients for determining the genotype and assessing the viral load. Next, please. Now, unlike hepatitis A, hepatitis B most certainly has a chronic carrier state. Important to realize that, as with hepatitis C, we now have reasonably effective antiviral agents that can cure this disease. Mothers who are seropositive for the surface antigen pose a 20% risk of passing infection to their baby in the absence of immunoprophylaxis for the neonate. And if the mother is positive for both the E antigen and the surface antigen, she has a 90% risk of transmitting infection to her baby in the absence of treatment. Next, please. Now, the key immunoprophylaxis for the neonate is presented here. The CDC now recommends that all infants, no matter what the mother's serostatus, should receive the hepatitis B vaccine during their hospitalization for delivery, 1 month later, and 6 months later. If a mother is seropositive, her baby also should receive hepatitis B immune globulin within 12 hours of birth. That's to cover or protect the baby against the initial high viral inoculum to which it's exposed until the point in time that its own vaccination induces immunity. Another very important point, not widely appreciated, not widely practiced, but I'd like to encourage everybody that's listening to pay careful attention to this, is that if the mother has a very high viral load, which is arbitrarily defined as greater than 1 million copies per milliliter, she also would benefit from being treated with tenofovir, 300 milligrams daily from 28 weeks until delivery. That drug, combined with the immune prophylaxis that the baby receives, is better than if the baby just received the immune prophylaxis alone. So key point, I think, there is the importance of tenofovir to reduce the likelihood of infection in mothers with very high viral loads. Next, please. There were 3 versions of the hepatitis B vaccine that were originally developed. So these are prepared, these are Injurex B, Recombavax HB, and Twinrex, which is a combination of hepatitis A and B vaccine. These are prepared by recombinant technology as opposed to being prepared from plasma of previously infected patients. All of them require a 3-dose series, and single booster doses are indicated when patients have sustained occupational injuries and have evidence of waning immunity. Next, please. Now, I would want to point out that there is a fairly new hepatitis B vaccine that has just been released commercially. It's called Heplisave B, and it has the advantage of only requiring a 2-dose series initially and then 4 weeks later. It's more immunogenic than the other 3 vaccines, and it's also more expensive than the others. Next slide, please. Now, hepatitis D, I want to just touch on briefly within the context of hepatitis B. The D stands for Delta, but I would think about this as the defective virus. This is a virus that cannot replicate independent of hepatitis B. Next slide, please. If this is an RNA virus, it depends upon co-infection with hepatitis B for replication, and the epidemiology of this is virtually identical to that of hepatitis B. Next, please. It can occur in 2 different forms in association with hepatitis B. One form is called co-infection. That's a situation where a patient has acute hepatitis B and acute hepatitis D. The more worrisome kind of co-infection is called superinfection, where you have chronic hepatitis B and chronic hepatitis D. And that's more dangerous because those are the patients who are particularly likely to develop chronic hepatitis, cirrhosis, and for some, hepatocellular carcinoma. Next, please. The diagnosis of hepatitis D is made by detecting the D antigen in either a liver biopsy specimen or in serum, or by detecting IgM or IgG antibody in the serum. Next, please. The relevance of hepatitis D is mostly good news. There is a chronic carrier state. Perinatal transmission can occur, but the great news is that the immune prophylaxis for hepatitis B completely prevents perinatal transmission of hepatitis D. Next, please. Hepatitis C, we want to finish with, this is more prevalent than HIV infection. It's now the most common reason for liver transplantation in the US. Over 3 million Americans are infected, 3 times as many as hepatitis B. We estimate that 3% of the world's population is infected. There are 6 major genotypes, and type 1 is the one that's most prevalent in the United States. Next, please. The sad story with hepatitis C is that of those who are infected, we estimate that 15 to 30% will progress to cirrhosis during their lifetime. And if you're unlucky enough to progress to cirrhosis, you have about a 1 to 3% chance every year that you'll develop hepatocellular carcinoma. Next, please. The best test for hepatitis C is an antibody test, an enzyme immunoassay. Now, there's some caveats that are important to recognize with respect to this antibody test. Antibody may not show up for up to 16 weeks after infection. And even though we're now on about our 4th generation of antibody tests, the antibody still does not precisely discriminate between acute and chronic infection. A key element in the diagnosis of hepatitis C is PCR, because it can be used to confirm the diagnosis and quantitate the viral load and determine the actual genotype of the virus, which is important in deciding on treatment. Next, please. Anybody with hepatitis C needs to be tested for hepatitis B, HIV. For sure here, liver function tests are very important. And if any of those are abnormal, a coagulation profile is indicated. Next, please. There is a chronic carrier state for hepatitis C. Perinatal transmission does occur, and that's particularly likely in women who are co-infected with HIV and who have very high viral loads. In the absence of either co-infection with HIV or a very high viral load, arbitrarily defined as greater than 2 million copies per milliliter, the frequency of infection usually is less than 5%. But with HIV and high viral loads, the frequency does exceed 5%. The infection is not transmitted by breastfeeding, so women can breastfeed without concern. There is no vaccine or hyperimmune globulin available for hepatitis C. I believe that universal screening in pregnancy now is indicated and is cost effective. We implemented that program at our hospital about 5 years ago. Next slide, please. Now, I put a question mark here as it relates to mode of delivery in patients with hepatitis C. And I want to indicate that I think the literature here can be just slightly confusing. I believe there is reasonable consensus that if you have a low viral load and you're HIV negative, that vaginal delivery is perfectly acceptable and does not pose an increased risk of transmission to the fetus or newborn. If you're HIV positive, I think the literature supports a scheduled cesarean delivery at 38 weeks prior to the onset of labor and ruptured membranes. Where the real controversy exists is patients that have a very high viral load but are HIV negative. Our policy at the University of Florida is to do a scheduled cesarean at 38 weeks in those individuals. I believe that you can tease out from the literature a tiny group of people who have a very high viral load, and you can show benefit for cesarean delivery in terms of reducing perinatal transmission. But I acknowledge that that certainly is controversial. Next slide. As I said, there is no vaccine available for hepatitis C, so preventive measures are ultimately of great importance here. Avoiding needle stick injuries in the workplace, using protective barriers to prevent splash injuries, and safe sexual practices. Next slide. The remarkably good news here, though, is that we have wonderful new treatment regimens for hepatitis C. The early treatment regimens were based on interferon and ribavirin regimens, and those were modestly effective, but not so well tolerated. We now have several directly acting antiviral agents, just as we do for HIV infection. They have many fewer side effects. They produce a higher sustained viral response rate. The problem is they've not been extensively tested in pregnant women yet. Next slide, please. I listed here 3 different combinations that have been widely tested and publicized. You see that the duration of treatment is relatively short, 8 to 12 weeks. What strikes you when you read the literature about these drugs is their remarkable cost. These treatment regimens will be in the $80,000 to $100,000 range for the full course of treatment, but they are highly effective. Next slide, please. 2 more treatment regimens, those slightly longer than the other 2. And next slide, please. The data seem to suggest that you can get a sustained virological response in 94 to 96% of patients, even those who have cirrhosis. Again, in the United States, the cost of treatment is quite expensive. Next, please. Take-home messages, I think, are for hepatitis A, the key to the diagnosis is IgM serology. Hepatitis A poses minimal threat to mother or baby, and it can be prevented entirely by hepatitis A vaccine. For hepatitis B, we want to remember that the key to the diagnosis is demonstration of the surface antigen and then PCR to quantitate viral load. B, unlike A, poses a high risk to mother and baby, but we have wonderful immune prophylaxis to protect the neonate, HBig plus HBV. And please, again, remember the little clinical pearl about use of tenofovir in the women that have a high viral load, beginning at 28 weeks gestation. Next and final slide, please. For hepatitis C, remember diagnosis with enzyme immunoassays. The confirmatory test is something called a recombinant immunoblot assay. PCR, very important for quantitating viral load and determining genotype. High maternal threat, intermediate threat to the baby, and management, I think, is selected use of cesarean delivery in a few patients, as I mentioned. And for hepatitis D, diagnosis by detecting the antigen and IgG antibody, low risk to mother or baby, and immunoprophylaxis for B protects against D. And thank you very much for letting me share those thoughts. And Mehmet, did you want to take questions now, or did you want to wait? Did we want to wait?
Actually, yes. And I do apologize. I was totally overwhelmed with the Zoom issue. So I skipped my dear colleague, Dr. Wen, and went directly to you. So, so why don't we take questions on the hepatitis, viral hepatitis in pregnancy? And I think we're running a little bit behind the schedule. So let's limit the questions for 5 minutes.
Sure.
And then Dr. Wen is going to present, and Dr. Wen and I will take the questions in relation to pregnancy-related liver conditions. So the platform is open to questions related to hepatitis in pregnancy to Dr. Duff.
Will these be verbal questions?
It will, they've been told to type them in the Q&A box. At the present, no questions have come in yet.
Ms. Allison, thank you so much for moving the slides forward. Not sure what happened there with our screen share.
Actually, it won't let us type in. Ivory.
Oh, someone sent me a question earlier, so let me.
I'm not seeing any questions being typed in unless.
I'm trying, but it won't let me type in on the question and answer part. Oh, there it is. Someone did it.
Tony, what's your question?
Oh, my question is, if you have let's say if you have multiple virus, mixture of A, B, C, and so on, does it put you at much higher risk for cirrhosis and other and maybe even transmission to the fetus?
So, excellent question. So hepatitis A, not really a chronic carrier state, and I don't really think there are tremendous long-term sequelae from that. The real problem is chronic hepatitis B, particularly when you're co-infected with D. That puts you at great risk for chronic liver disease, progressing to cirrhosis, and eventually hepatocellular carcinoma. And I think both that combination of B and D is as dangerous as having hepatitis C. And certainly if you had hepatitis C combined with the other two, you're at markedly increased risk for developing chronic liver disease, except that the wonderful new treatment for hepatitis C, as I said, can be curative in about 95 to 96% of patients. So here's a question. This physician has a healthy 30-year-old pregnant woman who's 4 weeks along, and she has hepatitis B surface antigen. Her viral titer is very low. She has normal transaminases. Would I treat her with Epivir? So I think I would not do that during pregnancy. I would make sure that the baby, of course, received the hepatitis B vaccine and HBIG. And then I think she should be referred to your hepatology colleagues for treatment afterwards, much as we now do for patients with hepatitis C. I think just right now, at least, we don't have an abundance of evidence showing that those directly acting antiviral agents are safe in pregnancy. I don't, probably in theory, if you think about HIV, we don't have too much reason to think that they might be dangerous. But if you want to go on the basis of the best evidence-based medicine, I would say we don't yet have enough data to say that those drugs are perfectly safe.
If there are no other questions from the audience, I have one last question. You mentioned the recent improvement in the treatment of hepatitis C. And you also mentioned that there is a 5% chance for vertical transmission, even in those cases without HIV. And of course, the consequences of hepatitis C can be very significant for the newborn and for his or her future life. Are there any trials or any safe alternatives among these new treatments that are surfacing for hepatitis C for use in pregnancy?
Well, that's Mehmet, of course, a wonderful, wonderful question. And I think, yes, there are, and I think they're in progress. And I'm aware of one small trial that showed the drugs to be safe. But I think, I hope that in the very near future, we can show, as we have done with HIV infection, that treating the mother reduces the viral load and basically reduces to almost zero the risk of perinatal transmission to the baby. You're right on target with that. And unlike hepatitis B, we don't have an immune prophylaxis. We don't have an alternate form of therapy. So that's going to be the hope, isn't it? The treatment of the mother.
Thank you. And I think we have one last question from Dr. Grauer. When would you treat hepatitis B, increased LFTs, high titers, and is treatment safe?
So I certainly would get help from our hepatology colleagues here and see if they think treatment might be indicated even while the woman is still pregnant. But I certainly wouldn't, even though specializing in MFM and infectious diseases, I don't think I would do that on my own, because I don't think we yet have enough data about the safety of the drug. And again, we do have for hepatitis B, we have really excellent immune prophylaxis for the baby, even when the mother has a very high viral load, as in like being co-infected with hepatitis E. So I think in this setting, I would provide supportive care for the mother, treat her with tenofovir at 28 weeks gestation to provide further protection for the baby, and then give the baby immune prophylaxis right after birth.
Dr. Duff, thank you so much. Again, we're running a little bit behind the schedule, so I would like to move to our next panelist. Actually, he should be following after me, but as I said, I was overwhelmed with the Zoom issues. So I would like to introduce my colleague, Dr. Tony Wen, who is the Division Director of Maternal Fetal Medicine and a faculty member at the University of Florida. He's going to present two, again, pregnancy-related issues. One is the acute fatty liver of pregnancy, and the other one is preeclampsia. So, Dr. Wen, please.
Okay, thank you so much. You actually gave me two nice diseases that have an easy cure, and both cure is delivery of the baby. The first one I'm going to be talking to you guys about will be about acute fatty liver of pregnancies. So the objective is to help you describe pathophysiology of acute fatty liver of pregnancy, to identify risk factor and early diagnosis criteria, and to formulate a management of pregnancy that's complicated by acute fatty liver, AFLT. And I don't have any financial conflict of interest. So again, due to limited data from population studies and also non-standardized diagnostic criteria, the incidence is quite varied. So anywhere between 1 in 7,000 to 1 in 20,000. And there's no geographic or ethnic factors impact the risk of acute fatty liver. And this, in the past, when I was younger, usually we don't make a diagnosis until the patient's very sick. So we usually think this is the worst type of similar to HELLP syndrome, but the worst type that you could have. But the spectrum is actually could range anywhere from minimal clinical and laboratory abnormality to overt liver failure with hepatic encephalopathies. And according to the U.S. Acute Liver Failure Study Group, acute fatty liver or pregnancy is actually the most common cause of acute liver failure during pregnancies. Now, in the old days, in the 70s, in 1940s to 70s, the maternal death is actually fairly high, up to 80%. And a more recent report by Sabai in 2009 is actually down to about 7.4% of lady with AFLP. And the perinatal mortality rate is also dropped a little bit more, and now it's about 15%. And majority of this occurred in the third trimester. There have been few reported cases in second trimester, but the mean gestational age is usually around 36 weeks. And the risk factors listed here, multi-fetal pregnancies, nulparous, male fetus, and fetus with fatty acid oxidation disorders, maternal obesities and maternal diabetes, and also other hepatic disorders such as IHC, and along with preeclampsia. Unfortunately, preeclampsia, the cause and effect is not very clear, but I know it's associated with that. But main thing is actually with this is they actually get confused with acute fatty liver is get confused with preeclampsia or misdiagnosed as preeclampsia many times. So in normal pregnancy, the fetal placenta unit metabolizes free fatty acid for fetal growth and development. So the placenta have a dehydrogenase enzyme that will break down the triglyceride into fatty acid, and that fatty acid will enter into the fetal compartment to be utilized for the growth. And this utilizes the long chain 3-hydroxy-CoA dehydrogenase enzyme, along with medial chain and also very long chain dehydrogenase enzymes. Now, so what happens is there's a defect in this fatty acid oxidation pathway. So what happened, it leads to accumulation of the different fatty acid intermediates and metabolites. And so that in turn enter into maternal circulation, since it cannot enter into the accumulation of this, stay on the maternal side, and then enter the maternal circulation, and then mom would uptake it into the liver. So here you can see the pathology. So the liver, this is a liver that's getting involved with that. And you can see within the stain, the liver, there's a lot of fat tissue within it. So this is evidence of fatty liver. And what it does is cause a microvascular fatty infiltrates. And as you know, fatty is along with radioreactive oxygen species will lead to a lot of inflammations and eventually lead to cellular hepatic necrosis. So the pathophysiology of this is that there's a maternal long chain 3-hydroxyase CoA deficiencies, and it's an autosomal recessive trait. And what happens is that lead to a mitochondrial functional protein defect. And what happened is there's about 1,528 G to C nucleotide change in the exon 15 alpha subunits. So what happened is that a lot of glutamate get changed to glutamine. And so this, as I mentioned earlier, there's also other fatty acid oxidation defects. So it could be the median chain, and also the very long chain could be involved, along with carnitine pulmonal transferase 1 deficiencies. And so it's actually two different processes that lead to this fatty acid and metabolite accumulation. So the fetus and the placenta kind of share either a homozygous or a compound heterozygous mutations, and that will lead to a defective enzyme. So then all these metabolites get built up, and if a mom herself is a heterozygous carrier for this defect, she actually, she doesn't have a disease, but what happens is that she has a decreased ability to oxidate the fatty acid later in pregnancy. So that's why it will accumulate more on her side. She can't get rid of it. So she's stored into her liver, and that's why this disease presents later during pregnancies. So there's different criteria. So Swanee was one criteria used, and they have a clinical features, a laboratory feature, and also ultrasound and histological features. So on the clinical side, it's a main thing is nausea, vomiting, abdominal pain, and a late presentation will be encephalopathies, along with polydipthia and polyuria. On the laboratory side, you can see all these are basically various liver dysfunction you see, along with glucose metabolized issues. So bilirubin is to be elevated, glucose will be low, mildly elevated white counts. The liver function, AST/ALT, be elevated. Can also lead to acute kidney insufficiency. So creatinine could be as high as 1.7, and ammonia level will also be rise, and could also lead to coropathy. So the PT, APP, and will be elevated, and urea will also be elevated. On the ultrasound, is a feature here on the top picture showing that there's an echogenic liver if you perform ultrasound. And histologically, what you see is a microvascular stuus. So on the on your left side, it's a normal looking liver with an artery and bile duct and a portal vein. On the right side is actually a stain and showing there's an accumulation of fats within the liver tissues. Now, the more common feature within this is hypertension. It occurs in about 70% of the patient. Nausea, vomiting, and that occurred about 52%. Abdominal pain, 49%, and jaundice in 30% of the patients. This is a algorithm that's used in Parkland for diagnosis. So the earliest indication they usually look for is a new onset of hypertension with nausea, vomiting, and abdominal pain. And so you can see up here is this will be the second column here for those symptoms, and a late finding again will be encephalopathies. And initial evaluation should be for clinical findings. So look at the white count, BNP, LFTs, LDH, and urine analysis. If it's normal, then you can back away. But if it's abnormal and it's suspicious for fatty acid, then at that point, then you want to do targeted laboratory evaluation and mainly look for liver dysfunctions. So that's where you start measuring the bilirubin, albumin, ammonia, and glucose and uric acid. And you also, along with that line, you can also worry about DIC, disseminated intravascular coropathy. So you will also measure the various coagulation studies. Now the cholesterol level would also be impacted. So you also want to normally it should be elevated. Fibrinogen and cholesterol should be elevated. But if you have a normal level, you kind of have to worry about it. It could be would be abnormal. It could be in the direction of acute fatty liver. But normally it's fairly low. And 75% of them would also have elevated ammonium, and some of them also would have pancreatitis. So you also want to check for amylase and lipase, hemoglobin, nuclear red cells, and eosinophil, just to see if there's evidence of hemolysis. Now, the authors, Nelson and the group, they did not recommend imaging because they felt like in ultrasound, you look for echogenicities. The CT, you look for decreased attenuations. If you do MRI, you look for an increased T1 signal. Now, they feel like the diagnosis is only it's accurate. It's only between 30 to 50%. So they felt that there's a limited utilization if you want to do imaging. The other thing you have to differentiate is there's other diseases that are going to have similar symptoms. So you have to look at different differential diagnosis. So the different diagnoses that have similar symptoms will be hyperemesis of gravidarum, preeclampsia, intrahepatic cholestasis, hepatitis, acetaminophen toxicity, and thrombotic microangiopathy. So you can see the onset is different. So acute fatty liver is a late diagnosis. So say mean gestational age is usually 36 weeks. All the other diseases like hyperemesis is early. Cholestasis, cholestasis is a little on the later side, but all the other one is variable depending on when the exposure was. And you can see the main thing a little different than the other for acute fatty liver is nausea, vomiting, in addition to hypertension, abdominal pain. And the liver function is only mildly elevated, whereas hepatitis and acetaminophen toxicity is much elevated. And same thing with the renal dysfunction, whereas again, it's mildly elevated, creatinine is mildly elevated, hematocrit could be go either way, depending on whether they develop DIC or not. Platelet definitely will drop down, which is so different than the preeclampsia, unless they have a health syndrome, which will be much lower. And all the hematology factor will also be abnormal. Fibrinogen will be dropping down, D-dimer will be going up, PT will be increased, and there'll be strong evidence of hemolysis. So Zhang in a Chinese hospital between 2009 and 15, they had 41 cases of acute fatty liver of pregnancies, and they compared to 172 other disease process with similar symptoms as a control to compare. And they were looking at all these different variables. So they were looking at history of liver disease, GI symptoms, elevated blood pressure, mild range, 140/90, elevated transaminase, total bilirubin, bile acid, increased time in APTT and PT time, thrombin time, mildly elevated white count, and low glucose. And they found out, they ran different models. And the model they felt like works the best is actually GI symptom along with aminotransferase, bilirubin, bile acid, and the bleeding time, the PTT. And the sensitivity of that combination, if those who are abnormal based on the value you see above, the sensitivity is 97.6%, and specificity is about 97.1%. Interestingly, they say if you add blood pressure in, or glucose, or white count, it actually decreases accuracies. And when I was a resident at fellows, we always felt blood pressure was a very strong, important criteria, and hypoglycemia was also a very important criteria. But the reason they were doing this is this allowed them to make a diagnosis early rather than late. So the biggest problem with when, as I mentioned, when I was younger, when we make the diagnosis, usually it's a late finding, and because our suspicion is not very high. And by then, patient is in much worse shape. So that the intent of this author is to try and help you make an earlier diagnosis and treat a little bit earlier. So the management, a lot depends on how the patients manifest, whether you find them in the early stage or versus in the late stage. But most important is a prompt recognition of the disease and assess maternal and fetal well-being. And you have to be ready to very intensive supportive care. It could be a mild one like fluid management, but it could also be a very severe one, require reversing the coagulopathy that the patient may have. And most important, you have to get ready for the delivery plan. So have some delivery preparations. And multidisciplinary team is very important. You need anesthesiologists involved, intensivists, because most likely this patient will have to go to the ICU, hepatologist, transfusion medicine, and neonatologists. They will be very helpful for you. Now, if there's any delay in delivery, until delivery, the liver failure will continue to get worsened. And the manifestation of the different laboratory and the clinical sign will also get worsened. Now, if you deliver them, the return will be slow. So you have to be patient in managing these patients. So be ready for a prolonged postpartum management. And intensive care support care could take up to weeks for it to completely resolve. The clinical course is basically a subacute or acute abnormality of those symptoms and labs. So it's very important to admit them to labor and delivery with ICU consultation, because you have to be prepared to transfer them to ICU. You will need an anesthesiologist right off the beginning, because the patient should become obtunded or develop hepatic encephalopathy, they will require intubations. They also recommend doing gastro NG tube placement along with an acid to neutralize any gastric content, because they're going to be vomiting quite a lot. And be prepared for postpartum hemorrhage, 2 large IV bore, and also be familiar with the massive transfusion protocols. And 70% of them will have associated preeclampsia. And for that reason, you have to be your magnesium sulfate ready to provide that. And they will all have severe blood pressure, so be ready to prepare to give the patient some IV antihypertension agents. And the fetus is more likely to be compromised, so also have your neonatologist involved. But fortunately, most of these babies will be closer to term, so it will not be quite critical in making a decision. The delivery plan, the mom is very high risk for developing lactic acidosis, and which will lead to decreased uterine placenta blood flow, and that in turn lead to non-reassuring heart rate fetal heart rate status. And for that reason, about 67% of the C-section is for fetal indications. Now, if the fetal heart rate status is reassuring, their recommendation is vaginal delivery. The reason is the mom is very high risk for DIC and bleeding disorder. So if you operate on them, you really need a good obstetrical and fetal medical indication to proceed with C-section because of the bleeding issue that you're going to have to deal with should mom undergo surgical interventions. If you do vaginal delivery, you also want to avoid any vaginal trauma or any laceration, and do not perform episiotomy if you could help it, because again, the bleeding is going to be significant. If you're going to proceed with C-section, then you need to make sure you have appropriate blood product available. Type and cross them, and you need to correct the coagulopathy first, okay? They recommend keeping the fibrinogen greater than 150 milligrams per deciliter and platelet greater than 50,000 before you proceed with a C-section. They recommend midline skin incision. Again, is that you're less likely, the few cases of a hematoma they got was from phantom steel skin incision. And the second reason is, they're going to have a liver dysfunction and everything else. So midline skin incision would also allow you to go up there and look, hey, is she bleeding into the liver or something else is going on? And they also recommend placing a Blake or Jackson Prep drain to monitor for bleeding. Postpartum is you're going to have a long course. So you need to continue the unfortunate physiological derangement will continue for up to 10 days. So you need to monitor postpartum for hemorrhage, DIC, acute kidney injuries, and the hematology, hepatic renal function need to be put, lab need to be drawn every 6 to 12 hours for 1 to 2 days. If you have preeclampsia, you need to give them magnesium sulfate. Make sure you check bang level because of the high risk for the AKI, and be prepared for multiple transfusions, multiple agents, transfusion products, and multiple units. If you have a surgical incision on a patient, you need to monitor the clotting function closely and be ready to transfuse with fresh frozen plasma, quadprecipitate, or platelets based on your laboratory finding and clinical signs. If there's evidence hypoglycemic, they actually recommend checking blood glucose every hours and then give them D5 infusion to resuscitate the hypoglycemia. Liver function will take about 1 to 2 days to return back to normal. Cholesterol and total bilirubin probably will take about 3 to 4 days to return to normal. And if they have AKI, it could be pre-renal or intrinsics, that one will take a little bit longer. It will take 7 to 10 days before they return to more trend toward normal. And this is some of the outcome you can see from various studies from maternal and fetal outcome from the acute fatty liver process. So again, the hepatic encephalopathy is anywhere between 15 to 53%, AKI between 10 to 94%, DIC is 16 to 80%, C-section, about 3/4 of them will get C-section, and maternal death. Some of these are a little bit older data, but the more recent data is actually more like 7.4%. And perinatal deaths, the more recent data is more like 15%. Other complications that could associate with this is they could 15% could develop acute pancreatitis. They could also have transient diabetes insipidus, and that's from the elevated vasopressinase because of decreasing and activating enzyme because of deficiency. So it cannot deactivate the vasopressin, so that's why you have a DI presentation. Unfortunately, some of them may require artificial liver support therapies. So you have to develop mechanisms to remove the toxins. And then you have the electrolyte and coagulation factor replacement to correct for that. And the patient may need to undergo plasmapheresis and also renal replacement therapies. Some of them, because of the cardiovascular or respiratory failure, they may have to be on ECMO, extracorporeal membrane oxygenations. And for some patients, they may require transplant. So the ECMO may be required as a bridge to get them to the point where they could get a transplant. There have been, due to failure to hypertension or acidosis, some patients actually do require liver transplant. And Parkland, they mentioned they had 2 cases, and unfortunately, one of them did not make it. And there's actually, in 2020, last year, they actually did a social media. So they went to the acute fatty liver group, and that's how they did a survey. And they asked, what's a recurrent acute fatty liver? And it's actually as high as 20%. So this is actually highest data that the most recent data is higher than any other previous study. So recurrent rate is 20%, but most of them have only a mild form of it. And the reason is because most of them they knew the symptoms, so they were diagnosed earlier and deliver earlier. So that's why they didn't get severe form of acute fatty liver. So in summary, acute fatty liver pregnancy somewhat rare, but it's a critical complications with mortality rate of about 7.4%. palm recognition is important. Look for new onset hypertension, nausea, vomiting, abdominal pain, and liver dysfunction in late pregnancy, around 36 weeks. And you need to have multidisciplinary team approach and be prepared for early delivery and C-section for fetal obstetrical indications, and be prepared with their blood products. And also you have to have your intensive support management team available. And that could be, as I mentioned, could be for weeks. Any questions?
Well, Dr. Wen, first of all, thank you so much for this very extensive review on a very serious, grave condition that we rarely encounter during pregnancy. When we do, we never forget it. So thank you very much. And actually, I think we are going a little bit beyond our time, and I don't want to keep anybody late. So I think we might have some time next week for your preeclampsia talk if you're available. So I'm going to end this session here, and I would like to take some questions focusing on the pregnancy-related issues, basically the topic that I discussed, intrahepatic cholestasis of pregnancy and acute fatty liver of pregnancy. Any questions?
Maybe I have one for you. So in your practice, do you draw the titer, the bile salt level? When do you do it? How often do you do it? And I know that's kind of dictate when you're going to deliver the patient.
So I think that's a very good question, and I don't have a clear answer. I mean, as you know, we get patients with itching, but no elevated liver enzymes. And then several weeks later, you check the bile acids again, and this time they were elevated. Now, how often should you check it? If they were elevated, let's say to 30, should you be checking them in a couple of weeks? Perhaps they go now beyond 100. And as I mentioned in my presentation, the level of or the severity of perinatal morbidities correlate closely. So I don't have a good answer. And part of the problem is that when you diagnose with ICP, you start, you interfere with ursodesoxycholic acid, and that would also impact on the bile acids. And, as I mentioned, some physicians choose to empirically start based on itching, even without abnormal liver bile acids, and that can mask the disease. So I don't have a good answer how often one should check. And I don't think we know much about the natural course of the disease without the treatment with ursodesoxycholic acid. So that's a good question, and I don't have a good answer. Let me ask you one question to you. So I guess, how would you counsel a patient who had a history of fatty liver disease, and is there any studies, any genetic studies, or any intervention to reduce the risk in her next pregnancy?
Well, from what I read, I didn't find too much on preventions. And as I mentioned, I think, again, it's the fatty acid oxidation deficiency defect that a patient have. And I guess if we're thinking along that line, then the question is, mom probably need to be tested to see if she's heterozygous or not, and then maybe the partner need to be, so that to see if they have increased risk or not. And the main thing is, I think early diagnosis is what's probably need to be be more sensitive to the symptoms, and then have the early diagnosis and treat them early to prevent the significant morbidity and mortality associated with that.
Great. So it's 8 o'clock, and I think we have half an hour left. So thank you very much. And I would like to move forward. And I wonder if my co-moderator, Dr. Zarpar, is here to introduce Dr. Morelli. If not, I will do it. Joseph Morelli is another faculty from University of Florida. He's a assistant professor at the Department of Gastroenterology, and he will talk to us about liver masses and pregnancy. And he will try to answer the question, what is dangerous and what is not in terms of liver masses identified during pregnancy. Dr. Morelli.
Hi, good evening, everyone. I'm Giuseppe Morelli, otherwise known as Joe. I've been at the University of Florida for many years. I've had the opportunity to round on multiple liver pregnant issues throughout my career, and they're probably the most stressful of all the patients I've seen, because you're not dealing with one person, you're dealing with two, and it's the most precarious time of any young woman's life, especially with delivery. So tonight we're going to talk about what we as hepatologists consider dangerous and what is not. We sort of have defined 3 lesions to look at. 1 are hemangiomas, 2 are focal nodular hyperplasia, 3 are the hepatic adenomas. Hemangiomas are otherwise known as hepatic venous malformations. They are the most common benign liver lesion. They are frequently diagnosed as incidental findings. And so the incidentalness of them, it kind of tells you that they're very benign. If I were to scan 100 patients outside of our hospital walking by, I would probably find a hemangioma in 10 to 20% of the patients. Now, from a radiological perspective, it's important to differentiate hemangiomas from hepatic malignancies, because on rare occasions, there are some vascular lesions like hepatoangiosarcomas that can have similar findings. They're usually congenital in origin, non-neoplastic, and almost always of the cavernous subtype. Blood supply is predominantly of hepatic arterial. Peripheral location within the liver is most common. And because, they're more common in female in a 5-to-1 ratio. They're rarely seen in children, but infantile hepatic hemangioma is the most common benign hepatic venous hepatic vascular tumor in infants. There's the extrahepatic hemangiomas. Then there's the associated ones with the Osler-Weber-Rondeau, the Kasser-Bach-Merritt syndrome with giant hemangiomas, and the hepatic arterial portal shunts. These are rare. These are the subtypes, typical and the atypical. The flash filling hepatic ones account for almost 16% of the hepatic hemangiomas. And you can see on this ultrasound image, a well-defined hypoechoic lesion. A small proportion are hypoechoic, which may be due to a background of hepatic steatosis, where the liver parenchyma itself is of increased echogedicity. Under color Doppler, you may see the peripheral feeding vessels. Now, this is ultrasound is usually the first modality that we often use. And oftentimes people get ultrasounds for other reasons. And that's when you will find a lesion of a sort. On a CT scan, their hemangiomas are relatively well defined. The dynamic enhancement pattern is related to the size of the vascular space. Features of typical lesions include the arterial phase, which we have here, typically shows a discontinuous nodular peripheral enhancement. Small lesions may show uniform enhancement. Now, this lesion is greater than 5.5 centimeters. And usually when the lesions get above 5.5 centimeters, where there's potential concern for rupture to the patient. And these are the ones that we sort of follow closely. On CT scan on the portal venous phase, you can see the progressive peripheral enhancement with more centripetal fill-in. And on MRI, you can see the on T1 imaging, which I have here, you have relative hypointense relative to the hepatic parenchyma. And these we do from time to time, nuclear medicine SPECT scans. They can be sensitive for larger lesions and typically demonstrate the decreased activity on initial imaging, followed by an increased activity on delayed pooled blood imaging. So as imaging has evolved over the last 20, 30 years, finding lesions has become a common theme. About 20 to 30% of all hepatic consults to hepatology services in clinics is because of a newly diagnosed lesion found on ultrasound for an underspecified reason. Now, because these lesions are considered low risk, and in the setting of a pregnant patient, if they have any prior finding of hemangioma, or if a hemangioma is found during an ultrasound during pregnancy, usually we may consider confirmatory exams, further imaging, MRI or triphasic CT or scintigraphy, and may consider follow-up ultrasound in 6 months to sort of assess stability, to make sure that if there is a concern that there might be growth, especially with the bigger ones. If you have a sub-centimeter or a 1.5 centimeters, usually we would do no further imaging. And as I mentioned, surgical resection for patients with having vague abdominal discomfort, and then you see a lesion greater than 5 centimeters. These are usually referred to my transplant colleague, Dr. Zarimpar, for resection. And the reason why I refer them to the transplant is because anybody who can take a liver out is going to be most comfortable at resecting a liver lesion. Now, as we move from the most benign, we move to the next type of liver lesion, the focal nodular hyperplasia. Second most common benign solid tumor. They account for anywhere from 2.5% to 8% of primary tumor lesions. Once again, there's a female predominance, predominantly found between the ages of 20 and 50. And, that's what predominantly during female reproductive years. You would expect to see these lesions. Characteristic features seen on imaging modalities. You see this well-enhanced hepatic mass. And on CT, you have this isoattenuated phase in the portal phase. And in the delayed phase, you know, isoattenuated hepatic mass in the delayed phase. So imaging is very important. And so in order to just oftentimes just the type of imaging modality we use, the sequencing, 3-phase CT scans or 4-phase MRI with EOVIST or gadolinium. The imaging modality is very important because it can help us distinguish these lesions without having to do any invasive, it's kind of having your own pathology, radiopathology. On MRI, you can see hepatic mass showing low signal intensity on the T1 image. So any of our abdominal radiologists here who see probably over 10,000 abdominal imaging a year, they can tell you very quickly on an image the severity of the lesion and the potential significance of that lesion. And that's what is great, having a multidisciplinary team. And on T2 imaging, you can see the subtle high signal of the lesion. Very distinct lesion that you see on MRI. It's something that right away the radiologist is going to say. And on the arterial phase, it's kind of like this gyrophone brain-like appearance. And on the MRI in the different phase, you can sort of see how it lights up. Now, in review of the literature, 2 main publications were of importance. One by Wyman et al. And the other one by Matthew et al. One followed 80 patients, the other one followed 216. They fortunately had 10 and 12 pregnant patients in their cohorts. What they noted in one cohort, one patient was pregnant twice, so they were able to follow this patient twice. They observed no change in tumor size during the pregnancy. And this is important because, you know, the question is, how often are you going to continue to monitor a pregnant patient in the setting of knowing that they have an underlying lesion? And identifying the lesion early on can allow you to utilize certain modality and also determine how often the frequency you need to follow. And also, you know, for those that are larger, you worry about the risk of hemorrhage or rupture observed. Now, the other thing they found is that there was no clear association with oral contraceptives with FNH lesions, and also nothing was identified in terms of size with hormonal changes that occur during pregnancy. Now, the downside to this literature is that, you know, it's a small number of patients. We're not looking at a large cohort of patients. It's a very small, but it's giving the benign nature of this lesion. You can say, well, okay, we'll follow and we'll just continue to monitor. Now, hepatic adenomas are a different breed of lesions. They are probably the most difficult lesion that we deal with next to hepatocellular carcinoma because they can be somewhat unpredictable. The epidemiologic data, for the most part, has been outdated. And the reason being is because we didn't really have very good imaging modality. It's only been in the last 10 to 15 years that we've seen some updated information even from the American College of Gastroenterology and from the European Association for the Study of Liver Disease, which put out guidelines respectively in 2014 and 2016, in terms of management, in terms of identifying, following these lesions. And that has a lot to do with, the changes in imaging modalities that have improved over the last 10, 15 years. Ultrasound, initially CT, and now MRI, with the various sequences, tumor sequences that we can do. We can clearly follow these patients. Now, these are associated with long-term oral contraceptive use. And so, the question always begs to ask is, if you're going to initiate somebody on oral contraceptives, or they've been on oral contraceptives for a prolonged period of time, does it warrant doing, an ultrasound to assess for any potential lesions? I don't think there's a clear answer to that, but I would be concerned of anyone who has been on oral contraceptives and was considering pregnancy to get a baseline ultrasound to sort of see if there's anything there. Obesity is another, so strong association with the presence of hepatic adenomas and also other metabolic disorders, MODY3 and glycogen storage disease. What has evolved over the last 10 years or so is the subgroups of hepatic adenomas. And as I earlier mentioned, these are very interesting lesions because they don't all behave the same. Some can transform into hepatocellular carcinoma, and others just can increase in size and then go into a phase where they start to involute and to a smaller lesion. Now, there's different forms here. And and you have the inactivated HCA type, the inflammatory, the beta-catenin activated, the sonic hedgehog, the mixed beta-catenin activated. And these are, pathologic findings that we see on pathologic evaluation. On MRI, this is a lesion, 9-centimeter lesion involving the right hemiliver, and these things can grow in size. And in some patients, we have they have even after surgical resection, they can recur. They're at risk of rupture, and given the proximity of this to the chest wall, any potential trauma to this patient can lead to rupture, bleeding. We unfortunately have had someone bleed to death from a motor vehicle trauma from hepatic adenoma. We've seen patients we've resected for hepatic adenomas who have gone on to have recurrence. So though they are not like hepatocellular carcinoma, they can behave in an interesting fashion, is that they can recur even after resection. So management becomes very interesting with these patients in terms of what to do. Now, this next slide shows, and this slide comes particularly from a study that was done in Europe, where they identified a patient with a Nolan hepatic adenoma, underwent pregnancy, became pregnant, and had a lesion that was a little over 6.5 centimeters, and then it started to grow and significantly early on in the pregnancy as a result of hormonal stimulation. And this one had to undergo transarterial embolization. And so during the pregnancy, they were able to burn the lesion and reduce the size of the lesion to avoid potential rupture in the later stages of pregnancy. Now, and this is the MRI showing this at postpartum. The lesion now is a little over 5 centimeters with a central necrotic scar after embolization. Now, the recent study that I will show, the premise to this study was a published review done by Colby and Salem in 2004. And the highlights of this report was that they showed there was a 44% mortality for the mother and 38% for the fetus when hepatic cellular adenomas were greater than 6.5 centimeters. But this data was a reflection of data that they had collected from the 70s and 80s from reports. Now, so this study done by Gaspers and et al. It followed 48 patients through 51 pregnancies. Each of these patients had a hepatocellular adenoma less than 5 centimeters. This is multi-center perspective study. This is some of the demographics here. They even looked at this, the subtypes. They tried to subtype each of these hepatocellular adenomas. The use of hormones usage before pregnancy, oral contraceptives, prior pregnancies, the use of fertility treatments, delivery, vaginal versus cesarean. And what they showed was at week 14, they had the initial imaging with the size. I mentioned to you earlier the one that underwent embolization, which there was a growth of 1.5 centimeters in a 12-week period of time during the first trimester. And then you can see some others which sort of did grow. Others like this one here where I'm pointing, it did go from 15 millimeters to 4 centimeters. And then after pregnancy, postpartum, it decreased in size. So there is some question of hormonal stimulation and then the removal of hormonal stimulation, how much does it affect, and whether removing hormonal stimulation can cause a regression in the size of the lesion. And then you see some that are stable. Now, the take-home message is for women women of childbearing age is that pregnancy should not be deterred. The minimal risk for there's minimal risk for lesions less than 5 centimeters. It's recommended that they get close monitoring and follow-up. As you can see, the most likely change you're gonna see is within the first trimester. There's a potential for increasing growth. And especially if you have one bordering 4 centimeters, there's a likelihood that you can get a larger lesion. There have been reported case reports of hepatic lesion rupture during pregnancy with loss of fetal life, and also of loss of the patient as well. Now, the importance of this study is that even though it was, it was an important study, but because of its limited sample size, they were unable to assess the effects of the hormone on the growth of hepatic cellular adenomas during pregnancy. So a much larger study would be able to assess, the measuring hormonal levels and seeing if there's a response with the change in the size of the adenomas. Now, the other thing is, as I mentioned earlier, there's various subtypes of hepatic cellular adenomas. And so each subtype, or there may be certain subtypes that may be a lot more at risk for to grow. So identifying these subtypes, you may be able to further risk stratify whether which population is going to be at greater risk instead of lumping them all into one category. And with MRI imaging, there is a difference in these different subtypes, but you need to have a larger number of patients with these subtypes in order to catalog them, and further studies are needed. Now, there's an omission on this slide. I just realized surgical resection remains the gold standard, but is not always necessary. And from anecdotal experience, from treating patients with hepatic adenomas, unfortunately, they can recur, and recurrence can lead to the point where they can involve more of the remaining liver, and they often necessitate the need for liver transplantation. So management, sometimes surgery itself may lead to stimulation of growth as a result of resection. Now, the patient in question in this study had embolization, and embolization may be an early or first line of therapy in some patients to sort of monitor, especially those who have increased in size. I have seen several patients have regression of these lesions, and so sometimes wakeful watching is necessary unless there's features of that they're at risk for rupture, or the person engages in high risk activity. I had this one young female who had hepatocellular adenomas, and she was an ultimate fighter. So she's a lot likely to get body blows to the abdominal area. So management of these lesions with surgical resection was deemed necessary. Now, the beauty of being in a multi-centered, being in a center that can offer multidisciplinary interactions allows us to better manage these patients. So anybody in the community who finds a patient with a lesion like hepatic cellular adenoma and is looking, or the patient may be pregnant, should be sending it to a tertiary center like ours, so that we can, amongst the different hats that we have, we can, have inputs in terms of management of these patients. And with that, I conclude.
Morelli, thank you so much for this nice presentation. I think we're coming to 8:30, so we will take perhaps one or two questions. And I see that Dr. Zarimpar is also here.
Hi, everyone.
Evening.
Any questions from the audience? Any comments? Dr. Morelli, I have one question.
Sure.
So how should I counsel a woman who is coming for preconception counseling with a mass that has been stable, with a hepatoma that is stable at 4 centimeters? I know that you said that you don't necessarily recommend resection prior to pregnancy, but in terms of the chances for this lesion growing during pregnancy and requiring embolization and the risk for bleeding, how should I counsel this woman? Or how
Well, I think initially identifying exactly what the lesion is. So assuming that this is a hepatocellular adenoma, I would make sure that I had the best imaging in terms of a good CT or MRI in multiple phases. I would review that lesion with my surgical colleagues to make sure that this is not something that is not considered just a benign lesion. And then if we say this is a hepatic adenoma, then if this patient was looking to become pregnant and becomes pregnant, then I would follow this lesion closely and see if there are any changes, and then do follow-up imaging at a later point in time to see if there's been any changes. I think close observation. I wouldn't discourage her from getting pregnant. Now, if she had, like our previous patient that I had referred to, Dr. Zarenpar, who he resected, and then I would get repeat imaging, and if she had several lesions, sometimes they can recur and they come with 2 little satellite lesions, then I would, continue to do close follow-up and just be a little bit more vigilant in the follow-up of the patient. And so this way I would not, I would act more on caution, but I wouldn't deter them from becoming pregnant. If it was a large lesion, and really large, like 6 centimeters or anything greater than 5, then I would have Dr. Zarenpar have his input to see if surgical resection would be beneficial for the patient.
Yeah, I mean, I agree. I think the other than the size, the characteristics, the beta-catenin ones do have an increased risk of rupture and bleeding, as well as malignant transformation. So really, we rely on our radiologists, as well as, if really in doubt, we may even biopsy these things to see what kind it is. Having that information helps. But yeah, I agree with Dr. Morelli. It brings a lot of anxiety when someone is diagnosed with an adenoma, 2-3 centimeters, and I've certainly had a lot of patients come to me crying about not being able to get pregnant, or if they become pregnant, having to decide. On the one hand, they're worried about dying from a ruptured adenoma versus having to terminate the pregnancy. And I think that we need the anxiety needs to be managed with investigation and with advice. But I think we also need to just let them know that this is, the decision doesn't need to be one or the other.
And am I correct to understand that the rate of growth is highest in the first trimester, but probably the risk of rupture is greatest in the later stages of pregnancy?
Correct. But it also, I think, it goes back to Dr. Zarenpar's point that the type of biology of these ones, and as we learn more and more as to which ones are more likely to become an issue, and sometimes maybe biopsying if we identify them before someone becomes pregnant or intends to become pregnant, that may give us a better understanding as the potential nature of these lesions, because not all of them behave the same. I've had a lady in the past who had a 9-centimeter lesion and went through 5 pregnancies, unbeknownst to her that she had a lesion until her last pregnancy, because she had very little prenatal care in terms of, did not have access to a tertiary center. And so nobody really knew until somebody imaged her for some unknown reason. But this lesion sort of regressed over time. So they are, I think that they are really interesting lesions because they're unpredictable.
Any closing remarks, Dr. Zarifar?
No, I mean, I think Dr. Morelli did an excellent job with the descriptions, and certainly the pictures are very helpful. Again, I think that this is obviously going to be a multidisciplinary approach to patients with these benign lesions. Radiology is really going to be our best friend. And it's nice that we can do MRIs and ultrasounds to follow these lesions. I've certainly had patients with, smaller, more benign looking adenomas who we've followed serially with ultrasounds. And, I think that both she and her medical team felt, safe and secure in being able to do that. And, she had an excellent, very safe pregnancy and is happy. But yeah, it's, it has to be multidisciplinary, it has to be close follow-up. We can get people through it.
Well, I would like to thank all our participants and panelists for attending. It's 8:35. I think we are all exhausted and hungry. So we hope to see you in 1 week at the same time. And you already have the program for next week. And as I said, I think we can ask Dr. Wen if he has any time, and we can add the preeclampsia perhaps. So have a good evening and see you next week. Thank you.
Thank you.
Thank you. Have a good night.
Good night.
Thank you.